So I've just checked that there is no bowel here. The transverse colon is safe below, and there is no small bowel as well. So the omentum is stuck with the earlier sutures.
Dr. Piyush?
Yes, sir.
Dr. Mumtaz here.
Yes, sir.
What precautions do you take to do the adhesiolysis at the edge of the defect? Because things are adherent. So, for the postgraduates, would you give some tips?
Yeah, usually make sure that you do not make the area more weaker there. You do not damage the sheath there. Do not go beyond the peritoneum. And obviously you have to look at all the structures there. Whether
Yeah, it's very badly.
bowel is not coming at any point of view. If so, this is a view from the epigastric region. If
Yeah.
at any case, if you are in doubt, you can always put some lateral, the 10 mm lateral port and have a lateral view as well.
Like pressure over the gastric region would give you some hint whether what is the content like.
Yeah, yes.
It is not
actually.
really sure whether it is a bowel or it is just an omentum. So, if some pressure is given over the gastric region, maybe it gives you some hint that probably it is purely omentum.
Yes, sir.
Very dense adhesion there.
Yeah, because it is stuck with the previous sutures.
Yeah, that's right.
That's the basic.
It seems that probably the omentum also has been taken in the suture.
I'm using bisector from the RB.
Oh, yes.
So this kind of push and pull will take the omentum out. So my whole idea here not to cause too much of bleeding as well
Oh, yes.
and bring the omentum out. You can see I should not really pull it very hard because there are vessels and
Some
Sister,
pressure over
yes.
the gastric region.
exactly. So there is compression
Yeah.
by the scrub nurse here. So just try to release the lateral adhesions as well.
As it is a 2D vision, so it becomes really difficult what is there behind. So
Yes, yes.
every
Although I have checked before,
yeah, that's
but I am still careful that any small bowel segment, if it gets in there,
that's right.
I do not injure it with the diathermy or even with the cold scissors. So these changes are because of the previous sutures, and probably I don't know if the mesh is exposed there, which is leading to the polypropylene mesh, which causes the dense adhesions.
This is the crucial part of the dissection because any hurry here would result into catastrophe.
Yes, so I'm not in hurry here. I would go very slow and try to, so the aim is not to leave any small part of omentum in the sac region, so that there is no chances of seroma in the post-op. I think you would have seen the polypropylene mesh there.
Yeah, it is very badly adherent.
And
Well
that is
seen.
why the adhesions are two-way with the polypropylene suture and with the mesh.
I think now it is clear that it is momentum only.
Yeah,
The
yes,
content. Yes.
Yes, exactly.
So in a
So like
you can-
it is not that we should think, it
Yeah.
should be proved that there is no bowel
Yeah, that's
at any stage. And if any omentum is left out, I would try to clear it at the end after reduction of the contents. My pull is also soft here because I'm I don't want to damage the proximal vessels of this omentum.
Yes.
I want this omentum to be alive. Two-way, it will not disturb me to remove it little later.
Right.
And second, I should not leave the dead omentum inside without
Yeah, that
vascular.
is a key because that leads to infection
Exactly,
and
sir.
lot of problem later on.
Exactly. So you can very well appreciate that now the adhesions are directly to the mesh there.
Dr. Piyush, Dr. Arvind here.
Yes, sir.
Just I want to know while reducing the content from the sac, just pressing the outside, can you give some additional advantage while for reducing the content?
The external pressure?
Yes.
Yeah, of course. Sometimes we have seen, because this is a recurrent hernia where mesh and sutures are there, that's why there is so much of difficulty. In most of the cases, when there is primary hernia which was otherwise irreducible, the pressure alone can, suffice.
Yeah, but in
And-
this situation, pressure alone won't suffice
No,
because
so
a
in
lot
this-
of dissection is needed.
Exactly.
And at the same time, we need to see exactly
can
what
see
is the
that-
content. Yes.
Yeah, exactly.
Because some part, even in spite of all efforts, some part of the momentum is badly adherent to the mesh,
Exactly.
the previous mesh,
Exactly.
which is not possible to remove.
Exactly. I'm trying to remove as much of momentum which will the momentum which would already have got blood supply at the distal end
Yeah, that's
from
right.
the abdominal wall can be left away.
Yeah, that's right.
The only aim is not to leave any avascular momentum there, which may otherwise lead to necrosis and seroma formation.
Does it look like a single defect or multiple defects?
No,
are
multiple
there?
defects. So
Kind of a
I
Swiss
started
cheese.
exactly, yes.
Swiss cheese hernia.
So I started with that, and I mean when I started, the external view was also like more onto the left side, but there was content even on the right side, which I am touching right now.
Yeah,
So
multiple defects are there.
exactly, multiple defects are there. Scan wise, it is a 4 centimeter defect, and
But it is very well being, evacuated. All the defects, the momentum, you are very nicely removing it
Thank
from
you, sir.
there.
Thank you, sir. So that is again in worry that to prevent any post-operative problems. So what would be your choices, sir, otherwise in this case? So I'm planning, because we had done lap chole for this patient.
Yeah.
That is why we are into the peritoneal cavity, and we just continued with, we planned for IPOM. Obviously, we'll be suturing.
Yeah, I think
The content-
you want to do IPOM plus, is it?
IPOM plus, exactly.
I think that would be a right choice. Dr. Rajesh, what is your opinion regarding this? IPOM plus or just IPOM?
So I feel the IPOM plus is always desirable because you have to restore the linea alba. But
Yes.
sometimes wider defects it may not be easy and may not be possible.
Yes.
So I'm not sure if you are contemplating IPOM plus. If you are contemplating IPOM plus, what kind of suture are you intending on? Is it going to be the barbed suture or some rolling?
So
I think this looks okay. This might be possible.
yeah, this
Yeah.
looks possible for me also.
Yeah.
Doesn't look very tough.
Yeah.
Probably there may be some tension, but we'll reduce the pneumo and we'll go ahead with the closure. Okay, I can see quite good distension here, although the scar is quite big. So what I do is I go at the lower end of the defect,
Yes.
and so I have confirmed that hemostasis is maintained there. There is no bleeding, and the very minimal momentum which is seen, probably it has a blood supply from the abdominal wall already.
I think it looks quite vascular.
Yes, sir. Yes, sir.
So I don't think there is any problem.
So usually we make a small nick towards the lower end of the defect. The thing here is I've started myself from the lower end,
Yeah, that's right.
and I took the needle inside there, and I'm just coming above. I'll take another one round and go back below. I'm trying to take at least 1 centimeter lateral edges so that my pull will not lead to too much of problem. I would also like to request the sister technician to reduce the pressure to
pressure.
10.
So what is the pressure now?
So
What kind of pressure?
actually I have already asked them to reduce, so now it is 10
10.
millimeter of mercury exactly, sir. So here tip is like whenever we are coming out, we can get the hold of needle where we want,
Yeah.
so that probably we may save some time and then adjust the thread. And I'm not taking all the thread at once inside, because that will confuse me, and so slowly I'm bringing in the thread. So this is what I was telling, that while coming out,
Yeah.
probably we may use this curve, hold it here and get the hold here, so that for the next stitch I'm ready without much wastage of time. So if you see, I'm not holding it with needle holder every time.
Yeah. That's
Rather, I'm just putting it in and pulling it like this. So that prevents,
the weakening of the suture.
yeah, exactly, yes, yes, sir. So whenever possible, obviously whenever required, I can hold it, but probably we can avoid it holding with the needle holder like this, whenever possible. So because it's a long suturing, for such a wide defect of 4.5 centimeters, if we hold many times, probably that will lead to weakening, and then towards the end, while we are just about to knot, and if it breaks, the anesthetist may break us if we go for resuturing. So here in our center, sir, we do IPOM plus even for 1 centimeter defect. If it is IPOM, it is always IPOM plus actually.
Yes.
So we have never left any defect open for last at least 10 to 12 years.
So
And that
frankly
is-
speaking, nowadays it is IPOM plus, not
Yes, sir.
only IPOM.
Yeah, so and this is our practice for quite long, because since the day we have joined here, almost 10, 11 years ago, the technique followed is IPOM plus. I'm planning to put 20 by 15 centimeter mesh. So this is from Covidian Peritex.
Peritex.
Yeah, it is polyester with absorbable collagen film. So usually the guideline and the standard choice is 5 centimeter on either all the sides of the defect. So that is not after suturing but before suturing. And whenever we have multiple species defect, so the last point is counted as the edge of the defect. And in this patient, I have taken a bigger mesh because of two reasons. Number one, it is a recurrent hernia I'm operating. I would like not to cause another recurrence for this patient. And second is coverage of the complete scar. So I can see 5 centimeters above and 5 centimeters below the umbilicus. The scar is the midline, and I am trying to cover that whole scar. Usually we take the center as the center of the defect, and here it was seen before itself. If you can get outside image, if you can get the outside image, so basically this was the defect.
Right.
Okay, and I came from the lower end of the defect. So this is the foot end of the patient
Yes.
where I'm tapping,
Yeah.
and this is the cranial end of the patient. Okay,
Yeah, that's-
so this is the foot end, and the defect comes up to here. So that was the question which was asked when I started with diagnostic laparoscopy, why this trocar is placed here
Yeah.
and not in the defect. So there are two reasons. One, for laparoscopic cholecystectomy, we do not want to go too lower in the abdomen, especially when the distance between the subxiphoid and umbilicus is high, as it is in this case.
Yes.
So if I place too low, the view on the CBD will be compromised. It will be a very flat view, and sometimes that alone can be a reason of CVD injury also. So we are actually basically fearful of that factor. So basically that's why we come almost like 3-4 centimeters above the umbilicus. We get a very overview of the CBD and calots.
Yes.
And second thing is, anyway, my plan was to keep a bigger mesh because it is a recurrent hernia, and previously one mesh is there inside, and this time the defect was also not very small but 4 centimeters. So probably I was in thought that I will anyway cover this area well above. So that was the second reason of placing this trocar above. If it was a primary umbilical hernia, then probably, as it was advised by one of the moderator, I would have gone with the defect. Through the defect, I would have placed the 10 mm optical trocar for doing lap cholecystectomy, which I did not prefer in this case. And as you can see here, the port positions, this is the Palmer's point where I inserted my first, on the left subcostal midclavicular line, where I inserted my first 5 mm trocar, after Verey's needle pneumoinsufflation.
Yes.
And then subsequently, after laparoscopic cholecystectomy, I placed another one trocar in the epigastrium, which is assisting me as an optical trocar for the IPOM plus. So basically, you can see that there are only 5 trocars here for complete procedure, including laparoscopic cholecystectomy with the IPOM plus repair. So I think it is good enough closure, probably not very good, but at least we could approximate. But as I think Dr. Mumtaz Ansari was suggesting, to go enough on the sheath rather than just on the peritoneum or the bare end of the muscle. So as you can see, you were in the another theater when I was putting this. The up, bottom to down suturing was done as a kind of double breasting, and I could, you can see that it is wide enough.
Well approximation.
Yeah, yes, sir. And if it was a little larger defect, probably in a very fibrotic scar, probably TAR would have been option. Endoscopic TAR would have been option, but here we could, manage well, and we are putting in a larger mesh, which will cover enough.
Large enough mesh to well cover the defect and 5 centimeter all around.
Yes, sir. Exactly. Yes, sir. So now this is another way. These are the prefixed central sutures. So exactly the outside nick will be on the midline. That will prevent mesh to go on either side. As sir very rightly said, because just say that it is 4.5 centimeter transverse diameter of this defect. So exactly 15 centimeter is the mesh size. If you move it 1 to 2 centimeters on the left or right, then you are deviating, and then we are again at the risk of developing a recurrent hernia if the mesh moves to one side. That is a well point given by sir. So this is head end of the patient.
Yes.
And you can see that almost like 3 to 4 centimeters I have coverage over this port site also.
So it is almost more than 5 minutes.
Yeah, yes, exactly. And this is the mid, this is the center of the scar, center of the defect.
Yes.
And almost you have 10 centimeters below here.
Yeah.
And 10 centimeters above here.
Yes, that's right.
So hopefully this will suffice. Yeah, yes. And we are covering almost like, this is 15 centimeters. So 7.5 centimeters here.
Yes.
On the right lateral side of the scar, and 7.5 centimeters here on the left lateral end of the scar. If you ask me the pain factor, I would prefer ETEP or the other procedures, and not intraperitoneal placement of the mesh. Okay, sir.
Everyone is witnessing your dynamic, involvement and your so much of sincere effort in organizing this conference and workshop. Are you using absorbable taps or non-absorbable?
Yeah, these are non-absorbable. Sorry, sir.
Non-absorbable
Yes.
tap.
We take out the needle holder here, bring in the sutures without bending the needle. Just the operator could operator could.
Mesh is well placed, I think. I mean, very nice
Yes, sir. I would.
placement of the mesh.
Thank you so much, sir. So you can see this again for postgraduates, that this turn should not should not be very deep also, and while tying the knot, there should not be too tightness. This is what I wanted to demonstrate, that it is not very tight. So the whole idea is to keep the mesh intact there. If there are some postgraduates, I would like to tell them that C and inverse C, there is no need to change the hand grip. You can just continuously do it. So I have not left the left hand grip. When it comes, it automatically becomes C here. And that is enough length for me. And this tip, they should again hug. And one of the instruments should remain static, like a left hand in my case, and one hand should be moving. After we have catch hold of it, just try to take only the left hand. Don't move your right hand. Take exactly the required length. Try to rotate, keep one hand static. And now what I wanted to show was, so now it is long. Just bring it near the center of the stitch area and pull the left hand. This is one technique where you will not lose the thread. And if you are short of thread, that is one thing, and you need not cut this end which falls into the peritoneal cavity. Another one thing is whenever we are doing suturing at the cranial end, that is the upper end of the mesh, it is better to do it at the later stages of suturing, because you will have a shorter length of thread and which will not come into your view. When you are away, that is this end, tail end, the leg end, there you can have whatever length of suture it is there. That is when we are just inserting the suture inside peritoneal cavity. So I came to this supermost suture at the end because I know that there is only a small length of suture is left out, and which will not cause much trouble here. I thank all the moderators.
Dr. Piyush,
Yes, sir.
are you able to hear us?
Yes, sir, I can. Yes, sir.
Actually, in a dual pathology or dual surgery,
Yes, sir.
like in this case,
Yes,
is
sir.
there any space for drain? Would
No.
you like to put in the drain?
No,
or-
sir, I don't know if you are there while lab
No,
cholecystectomy
lab
was done.
cholecystectomy was totally uneventful.
Yeah,
there was
so-
no spillage. There's
So
no
I think drain, there is no point keeping a drain here. It's giving more morbidity to the patient. Because we are not expecting any bile leak there. There was no bile leak.
Right.
We are not, there is no, hemostasis was quite well maintained. Thank you so much, sir. Thank you, everyone.
Thank you, everybody.
Thank you.
Thank you, Dinesh and team, the all.
Thank you, Anand sir and
Thank
team.
you.
Thank you, Sendil sir.